FGF, etc. Now, hepatocyte growth factor is one of the very few growth factors that's a mitogen, so it causes cells to cycle, proliferate, and regenerate, while it is also an immunoregulatory agent. It suppresses inflammation. So on the left, you see the normal response in tissues, very strong inflammation followed by some regeneration and then fibrotic responses. And HGF has been shown in a variety of models, both in vitro and also animal studies, that it can significantly suppress inflammation and suppress fibrosis while promoting regeneration. A number of studies that have been published in this space have been done in preclinical in vivo animal models, and they've shown that HGF is the principal factor expressed by mesenchymal stem cells that promotes regeneration in peripheral tissues. Here's a figure taken from one of those studies. You can see on the top, this is an algae brush model of scraping the corneal epithelium and anterior stroma. In a mouse model, you can see it takes 7 days for the defect to close under controlled conditions. When the hepatocyte growth factor is given topically, this happens much earlier, on day 5, and even day 5 is clearer with no sign of epitheliopathy as compared to day 7, where the epi is closed but there's epitheliopathy. Looking at histopathology, you can see the significant suppression of inflammation as well as restoration of normal corneal thickness. And so we thought, could this kind of regenerative approach also apply to limbal stem cell deficiency, an area of very significant need? The diagnosis, we all know as corneal specialists, is often missed or delayed significantly because people confuse it with other types of conditions. LSCD is often again diagnosed when it is late, and therefore it becomes a potential candidate for surgical intervention. So what about potentially using a medical approach to restore corneal transparency and improve the stem cell niche? The concept here is that provision of support for both the nerves which respond to HGF by regenerating, as well as the epithelium, could that potentially arrest the progression of limbal stem cell disease and potentially even reverse some of the pathology? So a prospective open-label study was conducted by Claris Bio to test the topical efficacy of a modified HGF compared to untreated controls, which received the vehicle alone. And you see the study design here. Basically, the blue shows the HGF, the orange is the control. And the key fact is that, as I'll show you, the inclusion criteria was including patients with stage 2 or stage 3 limbal stem cell deficiency, and they received 2 8-week periods of topical HGF, whereas the controls only received the topical formulation. So as you see here, from day 0 to day 8, they got the topical HGF. There was an observational phase ranging from 30 to 40 days when there was no therapy given, and then the therapy was reinstituted to see what effect that has. Looking at the inclusion criteria a little closer, again, as I mentioned, stage 2 or stage 3 LSCD, stage 1 MK was permitted. So these are patients with central involvement. The central 5 millimeter of the cornea was involved in the LSCD. However, we excluded patients that lost all vision or patients that had significant non-corneal morbidity, because then we would be unable to measure any potential improvement in their vision. And we decided to look at vision, or any improvement in vision, as a primary endpoint, along with some microanatomical changes as well, as measured by imaging. Very interestingly, as you can see here, we'll spend a little bit of time looking at this graph. You see the 2 curves, looking at logmar, looking at ETDRS, early treatment of the diabetic retinopathy study, ETDRS charts. So you can actually measure the number of letters that these patients can read. And we begin, obviously, at day 0, and you can follow in the ensuing 8 weeks. You see the dosing holiday there, from week 8 to week 12. Sometimes that was 40 days. And then therapy was again reinstituted and then continued until the last follow-up at week 20. what you can see is a very significant difference here between the treatment arm and the non-treatment arm. A couple of points. There is a progressive increase in the level of visual acuity in patients getting HGF. Secondly, you see that in the dosing holiday, there is a slowing down, or in fact, a reversal of that vision improvement. And then it restarts again once the topical HGF was reinstituted. None of the controls achieved any significant improvement in their vision. So now looking at the correlation between anatomical changes and visual changes, visual acuity changes, you can see here, let's look at the table on the bar graph on the right first. So we're looking here at the level of gain, if you will, in vision, and looking at also the change in the microanatomical aspects of the cornea. So as the central staining area decreases, you see a relative increase in vision. So we see a very close correlation between improvement in the health of the epithelium with the improvement in the vision. The therapy was well tolerated, so levels of patient complaints in terms of tolerability and adverse events are very comparable between the therapy and the vehicle. So in conclusion, we feel that a medical, potentially non-surgical approach for lingual stem cell disease is possible. Again, we're not advocating the use of a topical therapy for eyes with end-stage lingual stem cell disease where the entire cornea has conjunctivalized. Those cases will be, of course, candidates for surgical intervention. But if you have, let's say, a stage 2 LSCD where the central cornea is involved with epitheliopathy, and because of that epithelial irregularity and conjunctivalization, the vision has decreased. We feel that there is a potential for topical HGF to be efficacious and, of course, well tolerated. Of course, further clinical evaluation is planned. A prospective double-masked randomized trial is being planned, which will be conducted in 2027. Thank you very much.
We have again, like after every talk, 4 minutes for discussion.
I think 3.
3?
Yeah.
All right. Okay, we've got 3 minutes for discussion. So, but
I want to make sure. But,
I have.
No, you're right. 4. Go for it.
We just took 9 seconds.
But we've lost 10 seconds.
Well, my 3 minutes is your 4 minutes.
So, very important to know that this is only applicable for partial limbal stem cell deficiency. And amongst the partial, you find 2 types. One is there's a clear demarcation line between the normal epithelium and the abnormal epithelium, which is mostly we call conjunctivalized late staining epithelium. In those situations, as we published several times, if you take local anesthesia, a little sponge, and just brush away from the surface of the cornea on the slit lamp, all the abnormal epithelium goes away very easily. Within a week, literally within 7 days, the new epithelium grows. If the conjunctival epithelium is competing, you brush it away. That's why it's called sequential sector conjunctival epitheliectomy, and the vision improves. So it's a very simple technique. It's invasive. It can cause pain. You do expose the patient to risk of infection. You need a bandage contrast. So all those disadvantages potentially are there, but they probably could be offset by the cost at which this will be available for the patient to treat, and you see it takes up to 10, 20 weeks for the
pennies. It'll be pennies. It'll be very, very cheap.
It will be, yeah. So it might be the way, but where it's all mixed up and there's no clear-cut demarcation line between the normal and I think this will be the way to go, because there it will sort out the abnormal from the normal and get the central area covered. So I think that will be a very niche application for this, and we are one of the centers who might be in the study that might start next year.
Yeah. If I could just make one additional, and again, the data, of course, in the double-masked randomized trial will provide the answer. I think hypothetically there's an additional element to this therapy, in that again, we would propose, based on the findings, that we are actually providing some more support for the stem cell niche through various neuroregulation of the neuroimmune interface. And so it's more than just replacing the, if you will, dystrophic epithelium and permitting the corneal epithelial phenotype to move in. Because in that approach, which I agree, I mean, you've written beautiful papers on that, Harminder. The concern could be that that could very well come back, right? Because you're not really changing the microenvironment in the sensory niche.
Yeah, I think the other concept, just to quickly answer that, the remaining stem cells that are there, they promote their own niche,
Yes.
they promote their own chemokines or growth factors that support the whole surface. So you just to get rid of the abnormal, and there's sufficient redundancy in the normal that's left to give what you are proposing might be happening with HGF. But we'll see. Anyway, let's get on.
Thank you. So just looking from a broader angle, we know that, probably the most, the challenge we have with existing treatments is persistent inflammation in this eye. We know that, for instance, limbal stem cell deficiency transplantation most likely fails over months or years if there is constant chronic inflammation, as these patients have. So you show data that this substance also reduces inflammation. Do you think that there may be a role for chronic treatment, or to associate the corticosteroids perhaps or other to keep inflammation?
That's a critical question, not only in regard to the immune regulation promoted by HGF, but as you saw with the improvements, we didn't see any plateauing of the effect. So we really at this point don't know how long is the optimal period for the therapy. Do we treat for months and then stop and then restart? Or do we keep going? Is this going to be a chronic therapy? I don't think we have the answer to that, but we will be looking at that as a secondary aspects to the future study.
Yes, and what happens when you stop the treatment? That's also.
So that's one of the reasons why we had that interval in the middle, where for a month or more, for 40 days, we didn't give any therapy and we saw some regression. So it does seem like the eye, at least for the 20-week period, kind of likes this therapy. That's all we know. That's all we know so far.
From the pictures I saw on this, the data was shown, the vision improvement occurred despite persistent staining in the center. There was still some staining areas and staining patches in the center, but the vision improvement was quite significant. So that's a bit intriguing, and the explanation for that, I'm not quite sure what that might be.
There's a final point. Any data on, great data, I really like the study. Any information about HGF receptors in the corneal epithelium of the limbal stem cell that move this path? And if you can explain a little bit more how the hepatic growth factor modify in this drug is different.
Yeah, so this is just some minor peptide modifications that makes the manufacturing and the stability more. CMET, which is the receptor for HGF, is highly expressed by the cells of the limbal epithelium. So our next speaker is Dr. Victor Perez of Miami. Victor, come on up. Thank you.
Well, thank you again for the invitation, and thanks for all of you to stay this late here in our city in Sicily, and thank you so much. So I was asked to talk about ocular cicatricial pemphigo. How many of you see this disease and like to treat it? Okay, how many of you see it? It's a very important disease. How much you like to treat it, it's a matter of passion. And the data I want to share with you is, one of the questions that we ask is, do we have really good data to really make the decisions for treatment and diagnosis? I'd like to share something that was very curious to us. So ocular mucous membrane pemphigo is an autoimmune disease, it's a blistering disease. It's this chronic conjunctivitis that keep coming on and on in different ages. And we think of this as a chronic conjunctivitis, always taking topical steroids, but eventually this disease is actually a systemic autoimmune disease. It's an autoimmune disease. It's mediated through autoantibodies against base membrane proteins of the congenital base membrane. So some of these proteins have been identified. I'm looking more forward to identify them better, and we can do directed immunotherapy against this type of autoantigens. And what you see here is our diagnostic tool with this immunofluorescent, where we actually probe for immune complex deposition and complement. And we we always wonder, do we have the right biopsy? This is a classic patient from the ocular point of view. It was given to me by David Meixler when I was in Cleveland Clinic, and it's perfect. The patients have cachectic, some of these patients have esophageal involvement, skin involvement, and of course they have their dry mouth, ocular surface disease, and corneal disease, and changes secondary to the dryness, and tracheitis, and neovascularization. Although these patients do have a higher prevalence of glaucoma because of the increased episcleral pressure caused by the cicatrization. Systemically, this is the classic age of patients that we see. Very interesting, skin involvement and all involvement, other mucosal involvement are important. And I guess that's part of the message I want to relate to you in this talk. So we asked the question, and I was very lucky to have my star clinical research fellow, Dr. Robert Ruiz-Lizano, who's here with us today, and asked the question, really, do we have really evidence-based data on how we diagnose and treat these patients? So we actually did a very large retrospective study among 3 centers at Duke University, Mexico, in Spain, and thanks to my collaboration with Alejandro Rodriguez, we were able to analyze and do a pretty large comparison, very long term, from 1990 to 2002, of patients with OMPC that were seen at the Duke Center, Technological Monterrey, and the clinic in Barcelona. And these are the authors who were involved. And the method was to ask the question, what is related to the diagnosis, the other presentations, and comments on treatment. And the main outcome were inflammatory control, based on congenital inflammation 3 months after treatment, relapses, will patients relapse and why, or what are the risk factors, progression, and vision loss. And this is the first graph. So again, look at the time of evaluation. And we asked the question we asked, what's the tempo of control for inflammation after you start steroid-sparing therapy or anti-inflammatory therapy? And usually in a cohort of patients we evaluated, the median was around 3 months that it takes to get control of the inflammation. We tend to throw these numbers at, to our patients from what we read. So it's very nice to confirm this in a very strong study with a lot of patients. And when you look at the patients that get control of inflammation, 8 patients or some patients did not have complete control of the inflammation. So when we look at it at either univariable or multivariable analysis, what are the risk factors for these patients? Interesting, you see that the biopsy proven, actually in this study was pretty high, positive percentage for biopsy. So this makes a strong argument to do the biopsy. But never, don't forget it, your clinical gestalt is that this patient has cicatrizing mucous membrane pemphigo and your biopsy is negative. That doesn't mean that you don't treat accordingly. But it's interesting, so we look, what are the high-risk patients associated with persistent inflammation? Extraocular manifestations were very interesting. Esophageal, nasopharyngeal, and genital involvement. And when we look from what are the risk factors from the ocular point of view, a patient that presents with corneal scarring at baseline, it will be already at risk of having persistent inflammation. When actually you ask the question, what are immunosuppressive agents did? And as being reported, mycophenolate has a very good track record in controlling inflammation, as well as Imuran. And in the United States, we have and that was the strongest, our cohort was the strongest one with the use of biologics, rituximab, if an anti-CD20 antibody. And so you have a very, very good track record in controlling inflammation, at least with the short data with this in the study of at least 60 weeks. But we asked the question, what are the patients that had relapse? So in other words, they were controlled and have relapse inflammation. Again, with the high-risk patients, again, the patients with extraocular manifestation, including the esophagus, the nasopharyngeal area, and the genital area, are at high risk of having associated disease relapse. Corneal scar as well. Patients that come with a corneal scar at the presentation will be at higher risk also of associated disease relapse. What about progression, state progression? Once again, we did a univariable and multivariable analysis, and patients that were at high risk for extraocular involvement, once again, extraocular involvement, including manifestations, including the esophagus, this is the nasopharyngeal area, and the genital area, have higher risk of stage progression. And same thing with the corneal scarring. Patients that come already with the cicatrizing process of the corneal scar are also at risk progression for stage progression. What about risk for significant visual loss? Well, same thing. Patients come with extraocular manifestations that include the esophagus, the pharyngeal area, and the genital area, are also at high risk for significant visual loss, and as you can imagine, corneal scarring as well. So these patients, they have a common pattern of high risk factors that are associated with inability to get immunosuppression control, relapses if you get under control, scarring, loss of vision, and progression of disease. So based on this, we kind of put together our active ocular mucous membrane management algorithm. So of course, if you have a severe patient with corneal thinning and perforation, we had a great talk already how to deal with ocular manifestation of corneal perforation. Of course, if you need surgical management, and that was explained in the previous talk. And then you ask if there's signs of infections or non-infection. Of course, if there's infection, you need to deal with that and handle it accordingly. If there's no infection, then you will go quickly into the immunosuppressive phase with oral prednisone. As I mentioned before, it really gives me ability to control the inflammation in acute setting. And by the way, you can always remove it, right, and continue your immunological studies. And then you assess the degree of corneal inflammation. If it's less than 2+, use that patient, we can have the option of using mycophenolate. These are the doses recommended that we saw in the care of our patients, as well as the other steroid-sparing biological agents or antimetabolites. And it takes a while because, of course, these are oral medications. And if you have persistent inflammation or disease progression, then we move fast into rituximab or IV. In the United States, we have the possibility to use it. Don't forget about cyclophosphamide, either you use it IV or by oral formide. I always remember Dr. Dart from Mooresville. He loves cyclophosphamide. And it's true, for countries that you don't have rituximab, it's still a very nice option to use. And of course, if you have patients with a degree of inflammation that is very active, you can immediately jump into these two aggressive therapy. In the United States, we also have IVIG immunotherapy, and which is very complementary to either the cyclophosphamide or the rituximab. In fact, Dr. Steve Foster has a very aggressive protocol where he uses rituximab and immunoglobulin in a more aggressive fashion. If you still have persistent inflammation and disease progression, then you will have to control and actually try to achieve inflammatory control either by more pulses of IV steroids or adding antimetabolite, which can be also used for refractory therapy. And general considerations, right? So these patients, they're not supposed to be in steroids forever. It's, what you want is remission, no steroids, no inflammation, and this is algorithm that it will help. And as you saw from the data, at least 3 months of therapy is required to start seeing some anti-inflammatory effects. And we don't have the data, well, the 2 years data, we're still working on that, but that's what has been described. Finally, we protect the cornea. If patients have entropion or ectropion or the late disease, we strongly recommend these patients are controlled first. And before doing any oculoplastic surgery, protect the cornea. We published this in American Journal of Ophthalmology. And finally, this is a subset of a very difficult disease to take care of. So high-risk manifestation, esophagus, nasopharyngeal area, genital area, high risk, corneal scar, high risk. So keep that in mind when you see your patient with ocular scoliosis. Thank you.
Thank you very much for that. Very important, but so clearly laid out. One question, did you notice people who had interventions? So many of these patients need cataracts. And people who've had interventions, that changes the risk profile and how many interventions they've had?
Yeah, so we didn't look at cataract surgery or other interventions. This is much based on corneal scarring, which is the most common presentation they had. But no, in this large retrospective study, we did not look at any type of surgical intervention. But your point is well taken, because a lot of these patients will have significant scar.
And also about corneal sensations. Again, I keep harping on that many times because we don't routinely check it in every patient, but probably we should. And whether the nerve pathology in these patients, and we know there's a lot with almost every corneal disease has nerve pathology, what bearing that might have in your stratifying risk that might be another factor.
I think it's a great point. So right now we're really into corneal sensation. So we're doing corneal sensation in our center for all autoimmune patients, also patients with corneal transplant, patients with graft-versus-host disease, asking exactly that question. Can we use corneal sensation as a biomarker of progression? We're using two methods. We're using the cochegonnet and the non-contact sensitiometer that have been developed by Brill Engine. And we're still looking at the data now. I can tell you, in pemphigoid, we still don't have enough patients to make a statement. But in ocular graft-versus-host disease, yes, these patients present with a decreased corneal sensation, which for me is kind of like an autoimmune disease that you can actually track. And raise that population
Thank you
data.
very much.
Did you want to make a comment?
Thank you. There's certainly a subset of MMP patients who don't necessarily present with that classic relapsing conjunctivitis. That eye looks relatively quiet, and yet they have progressive cicatrization, and their biopsy may or may not be positive. I find it's a little bit more difficult to get those patients on board with the idea of immunosuppression when their eyes are not hurting them. So one, what is your approach to that? And two, do you feel like prognostically those patients do differently than the ones who have classic presentation?
I love that question. I have this discussion with my patients all the time. Yeah, so there's some patients, they're going to present to you, you have cicatrization changes, and then you ask your question, are they active or not? So you're actually talking with a patient, the conjunctiva is completely white, they have no symptoms, you have maybe a small singular referral, some scar tissue that might affecting the cornea. And then those patients, I have the conversation, I probably will do some lab work. We decided we do a biopsy or not, they're not active. And these are patients that I would feel very comfortable watching. So I do phototherapy, which is photography, and you see the patients come back and you act accordingly. Now, the exception to that is if the patient has a lid abnormality and requires surgery. If they're going to need some type of lid surgery, these are patients that I would probably start. I would probably go with mycophenolate, probably something like methotrexate, like 2 months, 3 months before the surgery, and then 3-4 months after the surgery, to prevent that exuberant fibrosis after surgery. In fact, in Florida, that's how we have so many patients. They come after doing oculoplastic surgery, patients that were not controlled. And that's what the AAO story is.
Question, Victor. I've seen patients who present without any extraocular involvement, but over the years develop extraocular involvement, even on therapy. So did you look at what proportion of your patients develop extraocular involvement? Because I look at them as kind of an intermediate, if you will, risk.
Yeah, so patients that first ocular and then eventually develop. No, I don't think so. I mean, that's the limitation, it's retrospective, but that's a very good point, because based on this, what I would do is if they slowly start developing extraocular manifestations, then you need to be more aggressive.
So this is just an index diagnosis.
Yes.
Yeah. Okay, thank you very much.
Thank you.
Our next speaker is Dr. Charlie Bouchard from Chicago on Stevens-Johnson's TEM.
So, SJS is a life-threatening T-cell mediated severe cutaneous adverse reaction to medication in a genetically susceptible individual with a characteristic rash, leading to apoptosis and necroptosis of keratocytes in the skin of these 2 mucous membranes. So it can be divided depending on the extent of the body surface area. So I'm going to talk about 3 areas: collaboration, innovation, and community. This is a multi-system disease that demands multi-system care. Intensive care units, specialized nurse, dermatologist, ophthalmologist, gynecology needs to be engaged in all of these patients. This is an acute care problem. Early transfer to a burn center. Stop and identify the culprit drug. Start supportive care. As we mentioned, the multidisciplinary care, and standardized ophthalmology care. You need to have an ophthalmologist there to manage. And then targeted systemic therapy, which is emerging, anti-TNF alpha and maybe JAK inhibitors to control early inflammation. This was a study done by Mass Eye and Ear, looking at the outcome of amniotic membrane. They looked at group 1 was 2000, 2007, they had patients that did not have amniotic membrane. Thomas John, actually from Loyola, reported the first case of amniotic membrane in SJS. They looked at patients grade 2 or 3 only, and in those patients, they looked at those that had amniotic membrane, either bedside or the operating room. And if you look at the outcomes, 20/40 or better, 100% of those patients that received that amniotic membrane were 20/40 better, and the severe complications were a lot reduced. This is the Sotozono grading system that was used in that study. Darren Gregory, about the same year, 2016, came up with another similar grading system. So we really need a protocol for assessing the grade of the SJS and then the treatment. There are a variety of treatment methods using amniotic membrane. It can be done surgically in the operating room. There was a great paper published looking at about 80 patients using dehydrated amniotic membrane and Procara if there was corneal involvement, and then cyanocrylate, at the bedside to avoid that. Collaboration, standardizing care. So the score 10, measures the mortality risk score. There's 6 objective values and 1 subjective, which is really looking at the total body surface area. This can be very difficult. There are a lot of potential challenges to getting this done, and perhaps an AI intervention taking the high-resolution photographs and providing a better, more accurate assessment of total body surface area would be beneficial. Prevention strategies, low-cost, single-allele genetic testing. Carbamazepine, as related to HLA-B1502, and in South and Southeast Asia, there's a higher allele frequency, and the cost is paid by the government, which is great, and it can be very effective, but not completely identifying all the patients at risk. There are also studies looking at multiple variant panels and anti-epilepsy drugs looking at sensitivity. And the results were fairly good with a sensitivity of 80%, specificity of 90%. So this would, encourage a cost-effective addition to new variants. Now remember that the HLA and ethnic association with SJS is pretty broad. We've been doing this for a long time. There are a lot of drugs that have HLA alleles assigned to them, and a lot of them have multiple alleles. Integrating pharmacogenetics into the health system, right? In Thailand and Taiwan, they have this. So the clinical decision support system, alerts, physicians that are prescribing drugs. It can offer a lower risk patients. Education. People have to learn more about the pharmacogenetics and the healthcare and understanding that in preventing Stevens-Johnson syndrome. International collaborations have been going on for a while to identify the genetic variants, as we just saw. Partnerships in public health and drug safety. In the U.S., FDA had 453 drug biomarker pairs in 2020. So already we're alerted to the genetic predisposition to allergic reactions. These collaborations need to continue in the future. National registries, database development, documenting regional incidence and prevalence of the disease. Patient referral networks are inadequate, and this may help. Identifying risk factors, treatment programs, and specific culprit drugs. Unmet needs, continue for evidence-based systemic clinical trials, which are difficult. Literally looking at long-term consequences of this disease is important. More coordinated care, and again, developing collaborative work networks. We're put together 8 programs in the U.S. and some international to try to, standardize acute management and look at the acute management protocols. Let's go to innovation. Pathophysiology. This is basically an antigen-presenting cell processing a modified protein of a peptide presenting to cytotoxic T cells, which activate, leading to perforin granzyme fast ligand, granulysin in the blister fluid, and maybe even systemically, leading to keratinocyte apoptosis and necrosis. This is a recent paper in 2024 looking really at very detailed multi-omic single-cell sequencing, looking at predisposition to cellular response and keratolysis, and then repair. So does the systemic treatment, prolong, affect the severity, duration, and mortality? Does it affect ophthalmic disease? Multiple clinical trials have been tried, but high-level evidence is still lacking for any single therapy. This is a review looking at all the different treatment modalities for acute Stevens-Johnson syndrome. Etanercept seemed to have the lowest mortality in this series of reviews. Predictive biomarkers. The SCORE10 is a ReSCORE10, a newer version of that. Kristen, that was published here in 2023 by the Japanese group, ABCD10. Some diagnostic biomarkers. Granulysin in the serum and maybe in the blister fluid may be a diagnostic biomarker for this disease. Certainly there have been prognostic biomarkers in the tears, IL-8, granzyme B, IL-1 in the serum, and certainly patients with NSAIDs, younger patients, and a higher ocular surface severity score. So, combining the biomarkers and known pathophysiology is where we need to go. Emerging on the microbiome, I don't know. It's very interesting. This is Jose Gomez's work published last year. We looked at SJS, Sjogren's as a control group, and finding a correlation between the ocular microbiome and Stevens-Johnson syndrome. Here they looked at the gut microbiome. Same groups, fecal samples showing a decreased alpha diversity and a decrease in Faecalibacterium, which provides butyric acid, which is an anti-inflammatory agent, and also it promotes cellular immune tolerance. Further, work needs to be done here, and taking more probiotics. We're not really there yet, but it might be an interesting avenue for targeted treatment. Community. These patients are really been a severe post-traumatic stress disorder. And we need to increase the patient's, participation in the care and developing protocols. We need their perspective. An integrated database biobank would enable some biomarker discovery and validation. We need to share the knowledge and look for funding for patients and continue with this work. Currently, there's a lack of a bridge between the hospital and follow-up care for these patients. They're not really addressing their mental health issues early enough. There's inadequate assistance and a lack of grief counseling for them and also their family members, and a lack of understanding about the PTSD associated with this. Well, better understanding the psychological impact and long-term health complications of these patients, providing realistic expectations when they get to the, to the burn unit, using a multidisciplinary team and really following their mental health. We put together a patient education booklet. It's in our burn unit. Every patient gets in, they and their families get this. There are a lot of support groups online that can be very helpful. We run a Stevens-Johnson support group meeting every August. August is Stevens-Johnson Awareness Month. Nationally and internationally, it's really a patient-run, event. Eye care. It's a narrow treatment window here for amniotic membrane. It's got to be done within the first week. So getting the patients acutely referred to a burn center is critically important. And then following a standardized care regimen, and then a lot of options for chronic care, which we don't have time to go into, but punctal cautery, buccal mucosal grafts have been very helpful, and Gita Ayala has been promoting that. So in summary, this is a complex immunology, immunopathology. The role of multi-omic assessments, I think, is important. There's a certain urgency of the diagnosis. There's a very great value in standardizing the care. When we need to kind of engage patients into this, the impact of collaboration, the importance of prevention, emerging role of the microbiome is unclear as yet, but I think there should be a renewed focus on the mental health of these patients, and having a long-term perspective is important, and strengthening our international partnerships. These are the patients we care for and serve, and we owe it to them to be more sensitive to their mental health needs. Thank you.
Rather than gone. Well done, John. I really, first of all, thank you for covering such an important topic. As you mentioned and emphasized, this is like a devastating disease for not only the patients, the families are often traumatized. Many of these kids end up getting this complication because of an antibiotic given to them for sometimes a trivial infection, and then boom, it's a real unfortunate incident. Question for you: the study on the microbiome that you referenced by Jose, Were the patients on treatment? Because obviously if they're on antibiotic or steroids, that's going to change the microbiome very quickly.
It's a very difficult issue, right? I mean, looking at the microbiome, because there are so many factors that are involved. And those patients were on hydroxychloroquine. I think some of them were already on that. So these are chronic patients, and they're probably going to be the more severe ones. So I think if you stratify the severity of the disease to get a little better group of, not really normal, but less affected by systemic treatment, then you would get some answer. But I think it's a very interesting area, and I put patients, chronic patients that are fairly stable on, probiotics and prebiotics, encouraging them that, this may not going to hurt you, and it may alter that microbiome.
Julia?
Very nice presentation. More on clinical management questions. So in my experience, big trouble can come after patients are released. I mean, if they survive, they have no corneal perforation, then they go home.
Yeah.
But then they have this, chronic, persistent ocular surface inflammation, which to me, remind a lot limbal stem cell deficiency patients after alkali burn, but whatever. Could you share, any advice on immunosuppression, if and how, systemic immunosuppression afterwards?
This is chronically, so
yeah.
It depends on the severity of the inflammation, and they cannot be on steroids. But mycophenolate is a well-tolerated drug, and if they have persistent inflammation, I think that works, reasonably well. I think you can manage a lot of the ocular surface disease, serum tears. It depends on the severity, but punctal occlusion, serum tears, and I think the bucket, the lid margin keratinization. That is the number one, clinical feature that needs to be addressed surgically. The question there, of course, is timing. When do you go ahead and do that? If they're on scleral lenses, and they don't have too much fornicel foreshortening, and they're doing well, then I don't really intervene. But if that's not working and they have chronic inflammation, a lot of them are just unresponsive. Remember that the pathophysiology here is a disruption of the innate immune response. Normally you have inflammation and then you have a restoration, you have a recovery. In SJS, that regulatory pathway is disrupted. So you have a chronic inflammation, immunologic inflammation, and that's what you're kind of referring to. So, I usually kind of start low and work high. So the mycophenolate, I think, can be effective for most patients.
One really important comment for the cornea specialists. I've seen many cases for all of the cicatrizing conjunctival disorders. Patients come in with cupped out nerves. So when your conjunctiva has a fibrotic disease, these patients are prone to getting ocular hypertension, glaucoma, especially when you're treating them with corticosteroids. Very often, again, the cornea specialists, we're not always very good at looking at the back of the eye. It's really important to monitor them with IOP checks as well as looking at the optic nerve.
Yeah, good point.
Yeah, great presentation. There's a lot of information to unpack there. You mentioned briefly about systemic treatments to use acutely. Our national reference burn center is the Sunnybrook Hospital in Toronto, and I think at this point they're employing either etanercept or infliximab acutely, which is something we don't do in Vancouver. Right. Just asking how your personal...
I'm not sure. At Loyola, we have, I think, 200 SJS patients in our database. And when Rich Gamelli, the former surgical chair there, he just refused the steroids. I know that in Japan they do pulse IV steroid for 3 days, and their results, and they have a tremendous, national network. They are way ahead of us for a network, and they use pulse steroids with pretty good benefit, pretty good outcome. So, but we don't use etanercept or maybe even the JAK inhibitors. That was kind of presented acutely. That would be a very interesting opportunity to treat that acutely. This is an acute disease, and the more inflammation, the higher the inflammation, it's just more difficult to control. So you have to get in there and be aggressive acutely. I think that's the main point.
Great. Thank you so much, Roy. Next speaker is Dr. Sajad Ahmad from London. Will talk to us about corneal melts. Thank you.
Great, thank you very much. So I'm going to talk about corneal melting. I'll go through, I think you heard some of the features in Dalia's talk, but I'll go through it again. It's not enough that we do on corneal melting. So I'll go through the causes. Remember, the corneal melting is a sign, not a diagnosis, so there is some investigation to do here. The investigations that we need to do, the medical and then the surgical management, because the medical management coexists with the surgical management here. So these are the range of patients that we often see in clinic. So you will have Murren's ulcer, for example, inferior melts. Just be aware that sometimes patients have exposure and that can be inducing it. So make sure you examine their eyelids. Rosacea, in some severe cases, I have a group of patients that have melted because their rosacea has been incredibly inflammatory and it causes scleritis. Infections, obviously, rheumatoid arthritis, which luckily, because there's better systemic control of rheumatoid, we don't see as much with those in melts at the moment, and then granulomatosis with polyangiitis. So I always think, we have a table that we use, but I always like to remind everyone the different causes. So if you're in clinic and you don't have a table with you, just go through all of these and make sure you tick the investigation. So B for vasculitis, infections, don't rule out, we discussed a moment ago, hepatic disease, both zoster and simplex, Terriens, autoimmune diseases of various shapes or forms, Murren's ulcer, which can often be very difficult to manage, pemphigoid, sometimes when it's causing an exposure, often because the eyelids stuck to the eye because of the symblepharon, neurotrophic disease, so don't remember, we've just heard about measuring corneal sensation. The biggest culprits probably underlying all of these diseases is dry eye. So for any ocular surface specialist, if you don't understand the management of dry eye, really you can't manage any of these causes. And remember, about once a month I'll get usually my medical retina team referring someone who's had a cataract or some form of retinal surgery done, and they've been put on a non-steroidal topically and it's induced a melt. So just be aware of the use of these in patients that have a pre-existing ocular surface disease. So remember, examining the patient involves taking a good thorough history, because if you don't, sometimes you'll miss things, and patients often, you'll go, you're fitting well, and they'll tell you that they had a renal transplant, as I had a patient a few weeks ago, renal transplant on immune suppression, so you have to prod and poke for information from them. Look to make sure what their faces are like. Have a look at the lid before we get them onto a slit lamp. Just make sure they've got normal lid closure. Is the eye red or not? Is this a quiet inflammation or is it an aggressive inflammation with significant conjunctival injection? Always have a look at the other eye because it actually gives you a lot of signs. So if one eye has melted centrally, the other eye might well have a very low tear breakup time, significant staining, because this is a Sjögren's patient, and it's the dryness from that that's resulted in perforating, probably because they've got an additional infection. Is this a central melt? So sometimes inflammatory melts tend to be much more peripheral. So if they've got a systemic autoimmune disease, central ones tend to have an infective or a dry eye component. And two important things: is this infiltrated, and is there an epithelial defect? Because if there's an epithelial defect, this means that you have to work very quickly, because these are the patients that will melt and perforate. And the last thing you want is to be taking these to theatre. So the investigations that we do are tailored to those diagnoses. So infection, do a PCR for HSV, serology for HSV, do Schirmer's on the other eye, chest x-ray. They may have other inflammatory diseases that get picked up, but also you need a chest x-ray for when you're immune suppressing them to make sure they don't have any latent or active TB. And then we do this whole raft of blood tests, some for diagnosis, some for subsequent management, because a lot of these patients will go on to systemic immune suppression. Don't forget serum ACE and anche for the associated inflammatory disease, sarcoidosis and polyangiitis. So the treatment of corneal melting involves local topical treatment and systemic treatment. Systemic treatment is obviously the mainstay, but you still have to manage the ocular manifestations. in the short term. So ensure they have full lid closure, and if they haven't, then we often in clinic will do a tarsorrhaphy, or at the minimum Botox, although I do think tarsorraphies work better for this. Reduce any toxicity, so if they've been using drops from over the counter, just make sure they've not got any preservative in, and lubricate these eyes as much as you can, because it will reduce, one, it dilutes out the pro-inflammatory cytokine of the tear film, and secondly, it helps promote the healing of the surface. Make sure you give them all of them topical antibiotics, because the last thing you want is for them to get an additional infection on top of this because of their epithelial defect. And then plus or minus antivirals at the later stage once you've got a diagnosis of simplex. Beware of the topical steroids. So the easiest thing to do with these patients is just to load them with topical steroids. That's the last thing you want to do, because the steroids will often induce a melt by preventing healing. So the treatment here is probably better with a short course of oral steroids than increasing any topical steroids. There's probably a use for them later on once you've controlled their systemic inflammation, and then as you withdraw that, you might want to introduce some low-dose steroid. Therapeutic contact lenses are very useful here to promote epithelial healing, but also to preserve as much of the cornea as you can. And if they do perforate, at least they've got a protective barrier. Systemic treatment includes oral doxycycline, because that is a protease inhibitor, and it will prevent further degradation of your cornea or sclera. Systemic antivirals, systemic immune suppression, we heard. Mycophenolate is a very safe drug to use. So whether you use it in this condition or in the other inflammatory diseases such as pemphigoid, chronic Stevens-Johnson syndrome, it's a very safe drug to use. And actually, we because we're a standalone eye unit, we tend to do our own immune suppression. And then we have biologics. So we have the newer drugs, the anti-TNFs, and there are newer ones coming around the corner for disease that isn't controlled by conventional immune suppressants. Surgery in this particular disease is complex and takes time, and if you're not used to doing it, you can run into problems. Before you do this, there has to be a plan medically, so you can't jump in and take these to theatre and operate on them, because there may be consequences to that. So you do your surgery, and then they continue to melt, so you then have to take them back to theatre. So make sure the medical management is controlled before you do this. If there is small perforation, you glue it. If there's a larger perforation, then you have to do a lamellar graft, as you saw in the earlier presentation. And either you do an anterior lamellar patch graft, or for central or paracentral perforations, we do DSECs, as you can see in the early section there. And actually they work very well for central disease, and are much easier to do in an inflamed eye. So to summarise, managing corneal melt is actually an acute eye emergency. So as corneal specialists, we would be expected to manage this soon. They can't wait to get into our next clinic. Make sure you look for what the diagnosis is, so ocular specific diseases versus systemic inflammation. And melts are infected or super infected until you've proven otherwise. So, using topical and systemic antibiotics is not going to harm the patient. Local treatment is very important, so you have to co-manage the surface of the eye whilst you're controlling the systemic inflammation, but be very careful with your topical steroids in the early setting, because you don't really know the cause at that stage. Systemic treatment is needed, and most of us who deal with ocular surface inflammation should have some experience in using systemic immune suppressants, and if you don't, I'll probably suggest that you get some with your rheumatology colleagues, because there will be situations in our careers where either you need to put them on very short and quick course of steroids, or use other conventional immune suppressants that are steroid sparing. And surgery is only failed medicine, so I think understanding the rest of the management is equally critical to the surgery that we have to do. Thank you very much.
Such a great, really amazing that you covered all this in 10 minutes. A lot of pearls in there. There are two things you mentioned that I think are critical, like really important. One is look at the unaffected eye. People often forget. There have been many published studies showing how the unaffected eye can become affected and actually progress to melt, because it's often overlooked. And then secondly, although the risk of a corneal melt from rosacea is really low, rosacea is so prevalent, but when you look at all the melts, there's actually a pretty significant chunk, like about maybe 5 or 10% that are from rosacea. And you should just remember that, because again, rosacea is treatable, especially with oral tetracyclines, as you mentioned, and so
I think the first point that you made is really critical. So I often when there's a melt patient, I always go to the other eye.
Right.
So everyone goes, well, that's a wrong eye. And the reason you're looking at it is because it gives you so many clues. And the last thing you want is for the same process to occur in the seeing eye.
Right. That's the baseline from which the affected eye started.
I just remember that, you know, pathophysiologically, a central melt is a T-cell mediated disease, where a peripheral melt is a vasculitic disease. So in a peripheral vasculitic process, drops are not going to work. So you don't use topical therapy to treat a peripheral disease. You know, if it's a rheumatoid patient with a central melt, I remember Flugfelder wrote a paper on that, right? He had all the graphs for central graphs. It was all T cells, not polys.
So if you have PUK with adjacent scleral involvement, that's a very strong sign that it's a vasculitic process.
And if I may add, I'm glad you brought that point, because I was going to mention it, and I would love to hear your experience as well in England and then elsewhere. We're really talking about a neutrophilic attack. I mean, especially in the periphery. I would not completely doubt in the central also happens. Not everything is black and white. And neutrophils are in the tears. So Klaus Dolman used to tell us a lot how useful the use of cyclophenolate glue was for that. Because not only did it stabilize the matrix, but it also prevented the influx of neutrophils into the cornea. Any experience in, did you put part of that step in your algorithm as well?
You know, this is where I think the contact lens, for example, will help. And there are many patients who, remember that if someone's got so much thinning that you've got decimase that's exposed, what's going to stop that from perforating is the epithelium. And the only thing that can grow quickly is the epithelium. And therefore, things like contact lens, amnion, these are the things that can support that. And probably, they also act as a barrier to preventing further influx of proteases.
The epithelium is the gate to inflammation.
Any comments from the panelists?
I was just going to make a comment about dissect, for the corneal thinning. It's a very interesting procedure, and I've done a couple of those, and it works really well. You've got a thick piece of tissue, and you buttress and tectonically support it from the inside. Depends on the severity. Once it gets a little bit more control, but
So the thing is, if you do a desect, make sure it's not a ultra-thin desect tissue that you get from that. You have to manually dissect it. You need thick tissue.
Go ahead.
I'm just quite curious your rationale as to the serology for HSV and VZV, since the seroprevalence is quite high, and I don't always find the serology to be fully reliable. So just wondering how that affects your approach.
The reason for the serology is that if it's negative, it really does help you because you've excluded one option. So and it's easy to do.
I think just a brief comment. I think in terms of pathophysiology, many times something that is not stressed enough is that the peripheral cornea relies for its nourishment largely on the limbal vessels. And when you have a vasculitic process affecting, that is not just inflammation that is damaging the cornea, but it's the inflammation that is clogging the arteries and therefore inducing necrosis. So it's not just inflammation. There was a paper back from the 70s where they tried heparin, and I'm not saying we should use heparin, of course, but the mechanism is also important. Just not inflammation, it's also lack of nourishment.
Okay, very good. So we can go to our last speaker, Dr. Denise Loya Garcia from Mexico City. Will talk to us about GVHD. Thank you.
Thank you very much for the presentation, and thank you all for sticking to the last meeting. And it's an honor to share this panel with all of you. So I'm going to talk today about the practical guide to manage ocular GVHD patients. And for the past 60 years, we've used hematopoietic cell transplantation for the treatment of some hematopoietic diseases. However, graft-versus-host disease still is the most common complication after this treatment. We know that it can occur from 30 to 50% of the patients, and it can be divided in acute versus chronic disease. And we know that having acute disease is the most important risk factor for developing chronic GVHD. As I mentioned before, pretty much between 40 to 70% of patients having this transplant will develop GVHD in one organ or multi-organ presentation. It can affect the skin, the GI system, the liver, lung, oral mucosa, and obviously the ocular surface. Here we can see the difference between acute and chronic GVHD. It was used to think that acute will be developed in the first 100 days after transplant, and it could be only involved in pretty much 3 organs, but we have learned that it could be presented in a multi-organ presentation, either acute or chronic. Here we can see how it develops. We can see that after the tissue injury, we're gonna see the activation of APC and macrophage that will release some cytokines, and then these cytokines will react into the immune system, creating this host disease. In the chronic side, we can see that it's mainly developed by 3 phases, and the most important thing is the loss of immune tolerance that will create at the end the fibrosis and the chronic organ dysfunction. Here you can see more clearly how this affects after the first injury and the radiation exposure. Here, T cells and B cells will create this chronic inflammation, alteration, the immune response and tolerance, and at the end, talking about the eye specifically, it will create the chronic and tissue fibrosis of the ocular surface. The NIH created this consensus and defined acute versus chronic accordingly to clinical manifestations and not the time of symptom onset as it used to be before. So it's really important to take this into account. We can see the patients with GVHD will present as SLK, PK, SPK, fibrosis, and not the typical dry eye. The highest risk will be pretty much between the 7 and 9 months after the transplantation, but it could go up until 2 years after the transplant. The typical presentation will be a dry eye, but also it will be accompanied by ocular surface disease. And as you may see in these patients, they are going to present with severe pain. Pretty much all of them will recall or say that it is like similar to chemical burns. Here also you can see that even most of these patients will develop neurotrophic keratopathy. They will be presented with a lot of pain, as I said before. So maybe this will be because of the infiltration of the tissue, but also because some corneal sensitization will develop after the injury. And these patients will be like trading one disease to another. They will be trading their cancer or their malignancies for an ocular surface disease that will be very disabilitating, and they create a very affected quality of life. So how will be diagnosing the GVHD? We have 2 groups, the international consensus criteria and then the NIH. The international developed by this ophthalmology group, it's mainly in ocular surface symptoms and signs, as you can see here, and also it needs to be accompanied by the presence of systemic or not GVHD. And the NIH consensus, it only represents with ocular surface symptoms. They eliminated the shimmer test, however, this is mainly used for not ophthalmology specialists. As I mentioned before, you have like a broader presentation of ocular surface disease, epi defect, fibrosis, scarring, SLK. And you can also use some complementary tests that we have available at the clinic, like osmolarity, mammography, non-invasive redness, and also some inflammation analysis as MMP9. And I want you to remember this image because here you have like a very small window of opportunity to treat these patients. Here in this study, you can see how patients were evaluated previously to the transplant and then after transplant, and you can see here how MMP9 tests will develop following the first follow year without any clinical signs. So this is very important to recall. Also, you can see here not only MMP9 but IL-8 that can be developed or will serve as a biomarker of ocular disease. Also, epithelial mapping, you can see that some progressive thinning is also presenting before any clinical data or clinical signs in these patients. And taking a look through the nerves as well, we can see that these patients will develop some inflammatory cells in the subplexus nerve imaging and some changes, as you can see, fibrosis in the stroma. So this is a small window of opportunity that we can take into account. MMP9 and IL-8 can be detected before any clinical signs and symptoms. MMP9 could be either negative at the beginning, but it can turn to positive. This is also very important to note. Peripheral thinning, we have pretty much all of us nowadays the option to take corneal epithelium images in our clinic and see if we are seeing some peripheral thinning, and also some positive corneal staining and inflammatory cells in confocal images. We also need to treat the phenotype that is affected. Pretty much all of the four that you are seeing here are affected in GVHD patients, so it's very important to treat accordingly while seeing this clinical presentation. And even though we used to see like the step-ladder approach for dry eye, in this case we need to take a step-down approach, and we need to be very aggressive at the beginning, and then control inflammation is very, very important. And obviously promote combination of different therapies in order to achieve this inflammation. So it will depend on what we are seeing in our patient, because every patient is different, but we can use a lot of these therapeutics that we're seeing here. Also, scleral lenses are often provided until the last cases or very severe cases, and we can use them even in not so advanced cases as well. What about new treatments? So a lot of new techniques and testing of the lacrimal gland and also tear of these patients have been done. And we have noticed that these patients have a lot of neutrophils in the tear. So new therapeutics have been done specifically to achieve controlled inflammation. Some of them were good, some of them weren't, but we can see now how these patients present with abscess and netosis in the ocular surface that can be achieved with different treatments, as topical dose heparin to treat or control netosis, as well as topical IVIG in some patients in combination with some steroids and artificial tears. So, as previously mentioned before, some JAK inhibitor therapies are now coming to treat these patients, and other, as I said, netosis and net targeted therapies are now under investigation. The recommendations in the ophthalmological evaluation standpoint, it's important to have a communication with the hematologist and have an ocular evaluation prior to transplant. Not only symptoms, but the ocular surface evaluation. And then 3 months after transplant is also recommended because we've seen in the studies before that this is a time when you can catch up the inflammation flaring up in the ocular surface. And obviously follow up every 3 to 6 months to see how the patient is going. And as I said before, this timing is everything. And as you can see here, Immunosuppression is something that is very important in this patient, systemic immunosuppression. However, systemic immunosuppression is going down after the first year. And as you can see here, when you are tapering this immunosuppression, you're gonna see the flare up in the ocular surface, so it's better to catch them up. So just to end, take home messages, lubrication is necessary but insufficient. We need to control inflammation very much. Obviously, escalate the treatment, but do an overall of all the inflammation and all the things that are going in this eyes. It's not only another dry eye, early diagnosis will make a difference, and we only have a small window of opportunity. And the future will be just not better diagnostic, but early detection to treat these patients. Thank you very much.
Denise, stay there for questions. Yeah. I know you want to sit down, but we'll keep you. Very, very nicely done. Thank you very much. Again, a very nice review. We've had the, I guess, unfortunate privilege of seeing about 35, 40 of these patients a week at our center. We see many, many of them. And I would say that in my experience, if I were to pick one therapeutic measure that's often overlooked is adequate punctal occlusion. Check the Schirmers. Again, recall the Schirmer test is specific but not sensitive. So if you have a Schirmer value of 0, 1, 2, that is definitely not normal. It is not normal. Okay, so that's very valuable. You're not going to get false positives. But you can have false negatives. You can have someone with significant dry eye with a Schirmer value of 10 or even 15. So check the Schirmer and be very early in your punctal occlusion. You can begin with the collagen inserts, if you will, if you don't want to use the silicone plugs. And then if you're dealing with someone who has a Schirmer of 0 or 1, and many of these patients have Schirmers of 0 or 1, do punctal cauterization. Very simple. It's done in a clinic. We've published our results. Yes, it's painful, but the whole thing takes like 10-15 seconds per punctum. So just keep that in mind.
No, so I've been very lucky to be in Dr. Dana's clinic when I was a resident and a fellow, and everything I learned from my clinic now in gravitas disease and Grayson, and those are great points. You know, Denise, congratulations. This is a very important disease. I love this disease because from the clinician scientist's point of view, you know, it's the only dry eye that you know when it's going to start. It's going to start 60 days to 90 days after a bone marrow transplant. So it really gives you the opportunity to really learn the immunopathology involved with this disease. It gives you the chance to be proactive. And my dream is to actually treat these patients during their bone marrow transplant infusion so you can prevent this. And so congratulations on working with your bone marrow transplant unit. Have you set up a nice system how to do that?
Not yet. It's been very challenging, mostly because where I work is not close to the big hospital, so we're mainly an ophthalmology clinic. However, some things have been discussed, and this exact treatment is not as common as here, as in the US or elsewhere. So, but yeah, I mean, the thing is, the first thing that you need to do is to encourage other specialties to know about it, because sometimes they don't think about the eye until the patient presents with some ocular discomfort. And as I mentioned before, I think pre-evaluation is very, very important, because whenever these patients are referred, they're pretty much all gone, you know, like a lot of inflammation, fibrosis. So I think the thing that we're starting right now mostly is educate our colleagues and try to establish a how do you say, like step approach, including ophthalmology previous to the transplantation.
So if I can give you some recommendations, I've been through this process twice already, 3 times in Miami, Duke, and now Miami. Tomorrow unit people, they need to know seen on time. You can actually have a very impactful approach to their therapy. And the sooner the better. It may not be before they come and we see them and we do the full evaluation. So we try to be very proactive. And you know, I agree, punctal plug for the dry eye patients, it helps very much. Don't forget about autologous serum tears or allogeneic. They actually work very well in this patient. You know, they have good blood, they have a new bone marrow, and they benefit from that. And you know, this is a T-cell mediated, T-cell orchestrated process.
So for me, the use of anti-T cell agents, as long as they're well tolerated, really helps a lot in the therapy of these patients.
Sure.
One last point, I would say that all these patients have meibomian gland disease.
Yeah.
They have it before they get the transplant. They get chemo, you do mybography, they're all abnormal. And I think that whatever you can do with the lid hygiene, maybe Mibo, I've tried Mibo, it seems to be maybe a little bit better, but they all have meibomian gland disease. So lid scrubs, hygiene, and I don't know about doxycycline, but I think it's a very important contributor to their complaints is the meibomian.
Yeah, we use a lot of oral tetracyclines in these patients. We do well. We heard the gong. I wanted to thank you, Denise. Thank all the panelists, the speakers. Important topics were covered. And thank you to SICSSO for having a session on the ocular surface. Thank you.
Oddio. Lavoro. Batta, no? Batta, no? Aspetta.